You ever notice those tiny bumps that sometimes pop up on your skin?
Hmm.
You might think nothing of them, right? Just little blemishes. But what if those, well, seemingly insignificant spots were actually clues? Little signals hinting at something, maybe something much deeper going on beneath the surface.
It's fascinating, isn't it?
Yeah, that's the question we're tackling today.
And it's truly remarkable how our skin, this organ we often just, take for granted, can serve as such a revealing indicator of internal health.
Definitely.
So when those small bumps take the form of tiny fluid-filled sacs, we call those vesicles, or pus-filled elevations known as pustules, well, they fall into a specific category dermatologists track quite closely: vesiculopustular dermatosis.
Exactly. And for this deep dive, we've gathered, well, quite a bit of information that's really laser focused on this specific area within dermatology.
Uh-huh.
Our mission today is to really unpack what's behind these seemingly simple skin changes. What initiates them, and maybe more importantly, what could they actually be telling us about overall health?
So let's maybe lay the groundwork first, the basics.
Good idea.
We're focusing on two key types of these small skin bump: pustules and vesicles. Now, both are quite small, generally under a centimeter across.
Okay, tiny.
Yeah, pretty small. The main distinction really lies in their contents. Think of a pustule as containing a thicker fluid, often whitish or yellowish, that's pus.
Right.
A vesicle, on the other hand, holds a clearer, more watery fluid.
Okay, so it's not just any bump. The content is a key differentiator. And the source material really gets into the nitty-gritty of how these form, the actual biological processes happening.
It does.
We're talking about things like edema, which is essentially with a buildup of fluid in the tissues.
Precisely, just swelling, basically. And then there's catholysis. This is where the connections, the sort of glue between the cells and the epidermis, that's the outermost skin layer, break down. They separate.
Oh, okay.
Think of it like the links holding the skin cells together dissolving in one spot. A prime example of a condition where this happens is pemphigus.
Okay, so a breakdown of those cell connections leading to these little fluid pockets. What other ways can these form?
Well, another important process is called ballooning degeneration. This one's often associated with viral
Okay,
infection.
viruses, okay.
Yeah, imagine a balloon filling with air until the cell looks all swollen, like it's about to burst. That's kind of a visual for what happens to skin cells when certain viruses infect them.
Interesting analogy.
Then there are proteolytic enzymes. These are enzymes released by neutrophils, a type of white blood cell, and they basically break down proteins. You often see this kind of activity in conditions like pyoderma, which is a bacterial skin infection.
So different contents, different cellular stuff happening, all leading to these bumps. The source also mentions degeneration of basal cells. Those are the cells right at the bottom layer of the epidermis,
That's them.
and that's linked to lupus. And finally, dermo-epidermal separation. That sounds serious.
It can be. It's where the epidermis, the top layer, actually detaches from the dermis, the layer just underneath. Bullous pemphigoid is a condition where this type of separation occurs.
Wow.
And it's worth noting that the primary system involved here is, of course, the skin itself, which is part of the body's exocrine system.
Right.
Now, what's quite interesting, you touched on this, is that certain breeds seem to have a higher tendency, a predisposition, to develop some of these conditions.
Oh, yeah, the signal that part was fascinating.
It really underscores the role genetics likely plays.
Yeah, it's almost like some breeds have a genetic roadmap that makes them, well, more susceptible to certain skin issues.
Mm-hmm.
Even though our sources don't specifically talk about pets, these conditions are often discussed in veterinary medicine, and these patterns might ring true for some listeners who are pet owners.
Exactly. It's very relevant in that context. For instance, lupus seems to be more prevalent in collies, Shetland sheepdogs, and German shepherd dogs. And pemphigus erythematosus, another one where the immune system gets misdirected, also shows up more often in collies and German shepherds.
It's like they might have a slightly different setting on their immune system, maybe making them more reactive in certain ways.
That's a good way to think about it. And the list goes on, right? Pemphigus foliaceus, another form, seems to affect Akitas, Chow Chows, Dachshunds, bearded collies, Labs, Newfoundlands, Dobermans, and Schipperkes more frequently. That's quite a diverse group.
It really is. Different shapes, sizes, coats.
It is. And bullous pemphigoid, the condition we mentioned with the separation of skin layers, also noted predisposition in collies and Dobermans.
Okay, those two breeds pop up again.
They do. Then there's dermatomyositis. This is an inflammatory condition affecting both skin and muscle, and it's more commonly seen in young collies and Shetland sheepdogs.
Young ones specifically. Interesting. And even some of the rarer conditions have these breed lengths, don't they?
They do. Subcorneal pustular dermatosis seems to crop up most often in schnauzers.
Ah, schnauzers.
And linear IgA dermatosis, which is very rare, is almost exclusively seen in dachshunds, according to our sources.
Wow, exclusively. That's quite specific.
It is. And then we have dermatophytosis, that's ringworm, a fungal infection. While it's not tied to specific breeds in quite the same way, it is generally more common in younger animals. Maybe their immune systems are still developing.
Makes sense. So these breed predispositions can be a really valuable piece of the puzzle when you're trying to figure out what's actually going on.
Absolutely. A key clue sometimes.
Okay. So we've established what these pustules and vesicles are and who might be more likely to get them, genetically speaking. Now, let's really dive into the why. What are the fundamental triggers, the causes?
Well, our sources helpfully categorize these causes based on whether pustules or vesicles are the main feature you see. One of the more common categories is superficial pyoderma.
Pyoderma,
Oh,
that's basically a bacterial skin infection, right,
yeah.
affecting the upper layers.
Exactly, just the superficial layers. And there are different ways it can look, like impetigo, which you sometimes hear called puppy pyoderma.
Right, seen in young animals.
And then there's superficial spreading pyoderma. Also, superficial bacterial folliculitis, which is inflammation specifically within the hair follicles.
Folliculitis, okay.
And the source highlights a really crucial point here. Bacterial folliculitis is frequently a secondary issue.
Secondary, meaning it's caused by something else.
Precisely. It often pops up because of other underlying factors, things like dermatosis, that's mange mites, or hypothyroidism, allergies. Even the use of corticosteroid medications can predispose the skin to infection.
Ah, okay. So in those cases, the bacteria are kind of like opportunistic invaders, taking advantage of skin that's already weakened or compromised.
That's exactly it. Then we have the pemphigus complex, which we touched on earlier.
The immune system attacking itself.
Yes, a group of immune-mediated diseases where the body's own defenses mistakenly target and attack healthy skin cells. Our source lists pemphigus foliaceus, pemphigus erythematosus, and panoepidermal pemphigus as different forms.
So the pemphigus family is all about the immune system attacking different layers within the skin,
Right.
which leads to these different presentations.
Correct. And there's a particularly severe form mentioned, pemphigus vulgaris. Sounds quite nasty.
It is, unfortunately. Unlike the other forms that tend to affect more superficial layers, pemphigus vulgaris causes really deep separations in the skin that very quickly erode into painful ulcers, often appearing in the mouth or where skin meets mucous membranes.
Ouch. Okay. So bacterial infections, often secondary, and these immune system misfires are major players. What else contributes to these kinds of skin issues?
Well, we also have that subcorneal pustular dermatosis, which, as we noted, is more common in schnauzers. Then there's dermatophytosis, the fungal infection, dermatosis, the mite infestation.
And a condition called sterile eosinophilic pustulosis. Here you see pustules filled with eosinophils, a specific type of white blood cell, but crucially, there's no infection present. It's sterile inflammation.
Huh. Inflammation without an infection triggering it. Interesting. And the list keeps going.
It does. Linear IgA dermatosis, systemic lupus erythematosus, and discoid lupus erythematosis, both autoimmune diseases, bullous pemphigoid, dermatomyositis, cutaneous drug eruptions.
The skin reactions triggered by medications.
Yes, and even epidermolysis bullosa, which is actually a group of genetic disorders that cause the skin to be very fragile and blister easily. It's quite a diverse list of potential culprits.
It truly emphasizes how similar-looking skin lesions can actually have very different origins at a cellular or even molecular level.
Absolutely. And when we think about risk factors, certain things can make an individual more susceptible.
Like what? What can tip the balance for some?
Well, the source specifically points to drug exposure as a risk factor for both systemic lupus erythematosus and bullous pemphigoid.
So medications again. A good reminder they can sometimes have unintended side effects.
Definitely. And as we discussed, it's worth saying again that bacterial folliculitis is usually secondary.
Right. So if an animal has allergies, maybe they're scratching constantly. That breaks down the skin barrier, creates an opportunity for bacteria.
Exactly right. And then there's the environment. Ultraviolet light sunlight is identified as a risk factor for several conditions.
Which ones?
Pemphigus erythematosus, bullous pemphigoid, SLE, DLE, and dermatomyositis. So exposure to sunlight can definitely play a role in triggering or worsening these problems.
That makes sense. So someone whose pet, maybe a collie or sheltie, spends a lot of time outside might be at higher risk for some of these light-sensitive conditions.
It's certainly a factor to consider.
Okay. So with this huge range of potential causes, how do you even begin to sort it all out? How do medical professionals actually diagnose these different conditions?
That's the crucial next step, isn't it? Diagnosis fundamentally involves carefully differentiating between all these possibilities. And our source outlines some key differences. Let's start with superficial pyoderma, that common bacterial infection.
Okay. The good news there, I suppose, is that it typically responds well to antibiotics if you manage any underlying cause.
That's the key caveat.
And diagnostically, if you take a direct smear, like from an intact pustule.
You'll typically see neutrophils, those white blood cells, often actively engulfing bacteria. The most common culprit is often Staphylococcus pseudointermedius.
Got it. Bacteria under the microscope.
And a skin biopsy in these cases will show neutrophilic pustules or maybe inflammation around the hair follicles, again, usually with bacteria visible. Now, let's contrast that with the pemphigus complex, the immune-mediated ones.
Big difference, I imagine.
Huge difference. The direct smears there will show lots of acantholytic keratinocytes, those separated skin cells we talked about, along with other inflammatory cells, but generally very few, if any, bacteria.
No bacteria.
And importantly, cultures taken from intact pustules will come back negative. No bacterial growth.
Okay.
Plus, direct immunofluorescence, that specialized test looking for antibodies stuck in the skin.
Right, the autoimmune hallmark.
So that will be positive in about half of pemphigus cases, showing those immune system proteins where they shouldn't be. Also, unlike bacterial infections, pemphigus tends to, wax and wane a bit, even with antibiotics, but it does respond to medications that suppress the immune system.
And there are nuances even within the pemphigus group for diagnosis, right?
Yes, absolutely. For example, pemphigus foliaceus and erythematosus tend to show that superficial acantholysis. They often affect areas like the face, the ear flaps, foot pads, but usually spare the inside of the mouth.
Okay.
And biopsies confirm the split is happening high up in the epidermis. Pemphigus vulgaris, in contrast, the severe one.
Deep ulcers, mouth often involved.
Exactly. And the biopsy shows the acantholysis, the split, is occurring deeper down, just above the basal cell layer. Suprabasal is the term.
Got it. Different location of the split.
Absolutely. And then we have subcorneal pustular dermatosis, that rarer idiopathic one.
More common in schnauzers.
That's the one. Direct smears show lots of neutrophils, but crucially, no bacteria. You might see occasional acantholytic cells, but not like in pemphigus. Cultures are negative, and interestingly, it typically doesn't respond well to standard steroid or antibiotic treatments.
So that lack of response can actually be a diagnostic clue itself.
It really can. Points you away from infection or typical inflammatory pathways.
Okay. What about dermatophytosis, the fungal infection? That seems maybe more straightforward.
In some ways, yes. A positive dermatophyte culture is obviously key. But it's worth noting that secondary bacterial folliculitis is actually pretty common with ringworm.
Ah, so it can get complicated.
It can. A skin biopsy will also show the fungal elements, which helps confirm it.
Okay. And for sterile eosinophilic pustulosis, the one with the specific white blood cells.
The direct smear is critical there. You see tons of eosinophils, but again, no bacteria, sterile. A biopsy also confirms eosinophilic pustules and inflammation. And diagnostically helpful, it usually responds really rapidly to glucocorticosteroids.
Ah, okay. Quick response to steroids points towards that. And linear IgA dermatosis, the really rare one in dachshunds.
The main diagnostic confirmation there is a positive direct immunofluorescence test, specifically showing IgA antibodies deposited right at the basement membrane zone, that interface between the epidermis and dermis.
IgA specifically.
Yes. The pustules themselves are sterile and just under the very top layer of the epidermis, the stratum corneum.
Okay. And what about the big autoimmune conditions like lupus?
Right. For systemic lupus erythematosus, SLE, it's multisystemic, affects multiple body parts, so the skin signs can be quite varied. However, a key finding is often a positive direct immunofluorescence at the basement membrane zone.
Similar to linear IgA.
Similar location, but it's usually different antibodies, like IgG or C3, not specifically IgA. Also, the ANA test, that blood test looking for anti-nuclear antibodies, is usually positive in SLE.
Okay, ANA positive for systemic.
Yes. Now, discoid lupus erythematosus, DLE, primarily affects just the skin, often those characteristic facial lesions like on the nose. Direct immunofluorescence at the basement membrane is also positive, but here the ANA test is typically negative.
Ah, so that ANA test is a key differentiator between the systemic and the skin-only forms of lupus.
Exactly. It's very helpful there.
And for bullous pemphigoid, the blistering one.
Again, positive direct immunofluorescence at the basement membrane zone is a key finding. However, unlike pemphigus, you won't see acantholysis, those separated cells, on the biopsy.
So what do you see?
Instead, you see the characteristic subepidermal cleft formation, that actual separation between the epidermis and the dermis, which leads to the blisters.
Different kind of split again. And finally, dermatomyositis, the skin and muscle one, often in young collies and Shelties.
The specific pattern of skin lesions, face, ear tips, tail tip pressure points, is a strong indicator. Biopsy shows characteristic changes like follicular atrophy, inflammation around follicles, basal cell degeneration, things like that.
Okay.
Importantly, direct immunofluorescence is negative in this condition. To really confirm it, you often need a muscle biopsy and an EMG, which measures electrical activity in muscles. Those will show evidence of muscle inflammation.
Wow. It sounds like putting all these pieces together is quite the diagnostic puzzle.
It really is a detective process. It's not just about seeing a bump. It's examining cells, testing for specific antibodies, looking at where the split is, sometimes even checking muscle tissue to get the full picture.
And what about just standard blood work, like a CBC or chemistry panel? Does that usually give you many clues?
Interestingly, our source indicates that, for the most part, routine bloodwork CBC biochemistry urinalysis is typically unremarkable in most of these conditions.
Really? So the skin itself often holds the most direct evidence.
Generally, yes. However, there are a few exceptions. With systemic lupus, SLE, you might see things like anemia, low platelets, or signs of kidney trouble like protein in the urine.
Okay.
And in sterile eosinophilic pustulosis, some individuals will have elevated levels of eosinophils circulating in their bloodstream, not just in the pustules.
So not always a smoking gun from the blood work, but sometimes it provides supportive information.
Exactly. Helpful pieces, but maybe not the whole story.
Okay. And we've covered a lot of specific tests. Just to quickly recap, the key diagnostic procedures seem to be direct smears from pustules, cultures for bacteria or fungi, skin biopsies for that detailed microscopic look, direct immunofluorescence, including specifically checking for IgA, ANA titers for lupus, and then for dermatomyositis, EMG, and a muscle biopsy.
That's a really good summary of the diagnostic toolkit. So once you have a diagnosis, let's move on to the crucial question. How are these conditions actually treated?
Right, you figured out what it is. Now what's the strategy to fix it, or at least manage it?
Well, one thing our source emphasizes is the importance of basic supportive care. Things like regular bathing with an antimicrobial shampoo.
Why is that helpful?
It helps remove surface crusts, scales, debris, and it helps manage any secondary bacterial infections that might be hanging around or trying to get started.
Makes sense. Keep the area clean, reduce the bacterial load, prevent complications. And for most of these conditions, it sounds like outpatient treatment is usually fine.
For the majority, yes, but there are exceptions. Severe cases of SLE, pemphigus vulgaris, and bullous pemphigoid can be quite serious, potentially life-threatening, and might need inpatient intensive care to get them stabilized.
Okay, good to know when a more intensive approach is needed. And then there are the medications. For straightforward bacterial folliculitis, sounds like antibiotics are the go-to.
Absolutely. Initial choices, often empiric meaning based on the most likely bacteria, include drugs like cephalexin, clindamycin, or amoxicillin clavulanic acid.
Common ones.
Yes. However, the source strongly advises, ideally, selecting the antibiotic based on culture and sensitivity results.
So testing the specific bacteria from the pustule to see which drug works best.
Exactly. To ensure you're using the most effective drug and, importantly, to help combat antibiotic resistance.
Makes good sense. What about the immune-mediated diseases? Pemphigus, bullous pemphigoid?
Yeah.
Those need a different approach. Right?
Yeah, they do. These typically require immunosuppressant medications to calm down that overactive immune response. Treatment options listed include drugs like azathioprine, chlorambucil,
Okay.
tetracycline, doxycycline, or minocycline, often used in combination with niacinamide, which has some anti-inflammatory effects, and also cyclosporine.
Those sound like pretty significant medications, really targeting the immune system. What about subcorneal pustular dermatosis, that Schnauzer condition?
The primary medication mentioned there is dapsone. It's usually given quite frequently at first until the condition goes into remission, and then the dose is gradually tapered down. Sulfasalazine is another option that can sometimes be used as needed later on to help maintain remission.
Okay, dapsone mainly. And for linear IgA dermatosis, the rare dachshund one.
Prednisolone, a corticosteroid, is often the first choice there to get things under control. usually followed by a slow taper down to alternate day therapy if possible. Dapsone can also be effective for some, but apparently the response can vary quite a bit between individuals.
So some trial and error might be needed there.
Uh,
And sterile eosinophilic pustulosis, the inflammatory one with no infection.
That one typically responds very well to prednisolone, again, often a higher dose initially until things improve, and then it frequently requires long-term alternate day therapy to keep it from flaring back up.
It sounds like corticosteroids, like prednisolone, play a really significant role in managing quite a few of these inflammatory skin conditions.
They definitely do. They are potent anti-inflammatories.
But there are definitely precautions associated with using them long term, aren't there?
Absolutely. Prednisolone can have a range of potential side effects, things like increased susceptibility to secondary infections, developing Cushing's-like symptoms, pot belly, thin skin, muscle weakness, potential liver issues, sometimes behavioral changes, increased thirst and urination, increased appetite.
Okay, quite a list. Definitely important things to watch out for. And what about some of the other drugs mentioned, like dapsone? Any specific precautions?
Dapsone can sometimes cause a mild anemia, maybe a slight drop in white blood cells, or a mild elevation in liver enzymes. Often these resolve if you lower the dose.
Okay.
However, there is a rare risk of more serious side effects, like a significant drop in platelets or white blood cells. And it's also noted that there are species differences in sensitivity. Cats, for example, are more sensitive than dogs.
Interesting species difference. Definitely factors to consider. What about sulfasalazine?
A key thing with long-term use of sulfasalazine is the potential for it to decrease tear production. So monitoring for dry eye, KCS, is important.
Good to keep in mind. And the more potent immunosuppressants, like azathioprine and chlorambucil.
These carry a risk of suppressing the bone marrow, which produces blood cells, and they can cause GI upset. Azathioprine specifically can also potentially lead to liver toxicity and pancreatitis in some cases.
Okay, serious potential side effects.
Yes, and cyclosporine, another common one, can cause things like vomiting and diarrhea, sometimes gum overgrowth, increased hair growth, occasionally wart-like skin eruptions, and it does increase the risk of infections because it suppresses the immune system. It can also potentially affect blood sugar regulation, and rarely there's a potential for kidney or liver toxicity.
So these are definitely not medications to be used lightly. Careful consideration and monitoring are key. Which leads us nicely to the importance of follow-up. What does that typically involve?
Our source provides some specific monitoring recommendations, which makes sense given those potential side effects. For patients on dapsone, it suggests monitoring their complete blood count, platelet count, and liver enzymes maybe every 2 weeks initially, and also if any clinical side effects pop up.
Okay, frequent checks early on.
Yes. For those on long-term sulfasalazine, checking tear production regularly is advised. And for any immunosuppressive therapy in general, close monitoring is essential. Typically every 1 to 2 weeks, right at the beginning when you're starting or adjusting doses.
Yeah.
And then maybe less frequently, say every 3 to 4 months, once the condition is stable and they're on a maintenance dose.
That makes perfect sense. Regular check-ins, lab work. It's all about catching any potential issues early before they become big problems.
Well, we've really gone deep today, haven't we? From those initial tiny bumps all the way through complex diagnostics and treatment strategies.
We certainly have, and I think the key insight really is that those seemingly simple skin changes, those little pustules and vesicles, can indeed be a window into a surprisingly wide range of underlying issues.
Yeah.
Everything from, common bacterial infections to really intricate immune-mediated diseases and even signs of systemic conditions affecting the whole body.
So even though the end result might just look like a little bump, the actual processes happening underneath at the cellular level can be vastly different. Really highlights the complexity of how the skin responds. It does, and as we've explored pretty thoroughly, accurately diagnosing the specific cause is absolutely crucial. It often requires that combination approach: clinical signs, direct smears, cultures, biopsies, those specialized immunofluorescence tests, maybe even muscle biopsies in some cases.
You really need to use all the tools sometimes.
Absolutely. And the right treatment hinges entirely on getting that diagnosis correct. It really underscores the importance of working with knowledgeable veterinary or medical professionals if you see these kinds of persistent skin issues.
Definitely. So here's a final thought to leave you with. Our skin is constantly interacting with the outside world and, as we've seen, reflecting internal processes too. What other seemingly minor bodily changes, things we might normally dismiss, could potentially hold deeper clues about our overall health? It's definitely something to ponder. And of course, if you are experiencing any persistent or concerning skin issues, it's always best to seek professional advice to get them checked out properly. Thanks for taking this deep dive with us today.